Quest for the Cure program. And before we start, I'd like one of our speakers to come up and bless our session here tonight.
You guys don't mind, I'm going to say the Pule in my native language of Fijian, if that's okay. Turagna tamai ke mami. Vinava levana veitavi na bomni kua. Na sotava na ketna marama. Marani sotava, marani garab takaratu bula. When a breast cancer, but the kina itavi ni kua. Vinava leva turagna ke mami. Maslak ni tombula ni kua, marani tosma binaka. Na bosne na bongindai. Sababi naktuyani, nikito loloma, takino susuma, and I then loloma. Amen.
Okay, good. We can start. And again, thank you very much for all of you to share this evening with us. Again, our topic tonight, I think is so important to the Cancer Center and to the community we serve, and that's about clinical trials. And so we have a very exciting program tonight. We have three speakers, including myself. My name is Jonathan Cho. I'm the medical director of the Clinical Trials Office here at the Cancer Center. And we have Ashley Springer, who's an advanced placement registered nurse who specializes in oncology. Will share her story from a nurse perspective. We're really honored to have Andrea Barcos from Maui, who's come and share her journey as a caregiver to her husband. And we have Monique Benavoy, who is really a clinical trials participant. So they're going to share their stories, and I hope we can have a lively question and answer after this. So I'll get started. This is, as you all recognize, the RUH Cancer Center. This center was built a bit over 10 years ago. The architect of this center was actually a cancer patient. So his heart and soul went into this to develop this cancer center. So we're blessed with this structure here to do the work that's so important to the community. So we'll talk a little bit about clinical trials here. I'll give you a little summary about as I'll segue into what are more interesting speakers later. So what is a clinical trial? So I'll try to define this. There's many definitions. But really, a clinical trial is a research study in which one or more human subjects, and that's what we do here, are prospectively assigned to one or more interventions. This may include placebos or other controlled treatments or interventions, and that's to evaluate the effects of interventions on biomedical and behavioral health-related outcomes. There are many types of clinical trials. We hear many about treatments, but there's trials for prevention of cancer, early screening of cancer, supportive care, such as medicines to control some of the side effects of our treatment. We do laboratory science clinical trials, healthcare delivery. How do you deliver cancer care? Telemedicine would be a good example. We do a diagnostic testing clinical trials. We do several here right now. And most importantly, we focus a lot on quality of life clinical trials. So there are many types of clinical trials. Why are clinical trials important? Well, we all know that research brings hope for many patients with cancer. Everything we do today in terms of cancer care delivery are the result of clinical trials. And if we're going to move the needle forward, in not only cures, but also advancing the lifespan of our patients, research is going to be the key. There is a fairly good correlation between clinical trial participation and cancer survival. This is best exhibited in a pediatric group, where clinical trial participation is well over 50%. And we have seen that, as you know, overall survival for cancer has dramatically improved. We're only beginning to see this happen in the adult population. But it is important that there is a correlation between how much clinical trial participation is and what impact we make in overall survival of cancer. I think we can appreciate that many of the standard treatments we do today were clinical trials 5 to 10 years ago. And having been in this field for over 30 years, I can tell you there's so many instances as I look back on what we did in clinical trial work has now become the standard of care. And what we do today in clinical trials, I can envision, will lead to greater and better treatment for our cancer patients. Well, what's the benefits of clinical trial? Well, it does allow one to have access to new and novel treatments and approaches. That's important. It contributes to cancer research, which we see is so important to how we're going to deliver care for patients. But also, I think it's important to realize that participation in a clinical trial, it really allows one to have the highest quality of care for several reasons. One, it gives an increased oversight that is mandated when someone goes on a clinical trial. They're standardized and scientifically reviewed treatments. A lot of these treatments and trials have gone through a lot of thought by thought leaders throughout the country. And there's mandatory quality assurance that goes with every participant on a clinical trial. There are many phases of clinical trials. So the whole process of taking a treatment or any intervention from start to finish can take decades, but average about 9 to 12 years. And it starts with the preclinical, which is really the laboratory phase of finding a specific treatment. After that has been established, phase 1 trials usually involve looking at toxicity, but also looking at dosing. What is the maximum tolerated dose that one can apply to a particular population? So this is not looking at how efficient the treatment is, but what is a tolerable dose? Once you've established that, you can go into a phase 2 trial, which will look at that dose of that specific drug in a number of cancers. And that, again, is phase 2. And once we've established there is some effectiveness in a particular tumor, then phase 3 trials will look at that specific new treatment compared to what is considered the standard of treatment at that time. So you can see any intervention, in most cases, new drug therapy, goes through a very, very intense evaluation period of phase 1, 2, and 3 trials. Phase 4 trials are usually trials that are done for long-term side effects after the drug has been approved, usually as a result of a phase 3 trial. Who can participate in a trial? Well, it depends on the nature of the trial. But for every trial, we have inclusion criteria or factors that allow volunteers to participate. We have exclusion criteria, factors that disallow volunteers from participating. And these criteria are many, and sometimes very burdensome and restrictive. These include age of the patient, the gender of the patient, the stage of the disease, what prior treatment this individual has had, or other medical conditions, what we refer to as comorbid conditions. Now, why do we need to do this? Well, the reasons are, number one, we need to identify the appropriate participants for that particular trial. We need to promote patient safety. By all means, that's the number one criteria. We need to make sure patients will be safe on this trial. And we need to ensure that the researchers learn from the information that they need by having the appropriate patients on that trial. Well, cost is important, right? I mean, this is one of the leading reasons why participants do not participate, is they're concerned about the cost of being on a trial. So there's research costs, that means related to taking part in the clinical trial, such as drugs, extra doctor visits, and tests that are solely for the purpose of research. And these are all vetted and has to be evaluated for every trial. But in many instances of all, the study of the drug company will pay for them. Well, what is the cost to the patients beyond that? Well, in many instances, routine costs are usually covered by an insurance carrier. Medicare covers. And in Hawaii, we're very fortunate because HMSA, if a trial is National Cancer Institute approved, they will pay along the lines of Medicare. So these are doctor visits, hospital stays, laboratory, whatever is considered a standard for the care of that patient, HMSA will pay for it. So that's a big plus for us here in Hawaii. There are many stakeholders when one participates in a clinical trial. It's amazing how many people are involved for each patient that is put on a trial. On the left, you can see that there's community healthcare providers, healthcare systems, academic centers such as the UH Cancer Center. We have government agencies depending on insurers, but it's all patient-centric. The patient is the focus of all of this. Like along that same lines, it's very important that the patient has a support system, right? And again, very patient-centered, caregivers, support staff, and families all come into play when someone is put on a clinical trial. And then you have your research team, and this is just part of it, but you have someone who is a principal investigator of that trial that provides the oversight for every patient that is placed on that trial. You have a research nurse. You have clinical research support staff or associates. We have your treating physician, who may not be the principal investigator, but certainly communicates with the principal investigator. And we have all this data people that are getting all the information that has to be reported to whatever agency is sponsoring the trial. But again, the patient is the center of all of this attention. There are myths about clinical trials that I'll share with you, and I'm sure these will come up in question and answer. First of all, clinical trials are only for advanced cancer when no other treatments are available. Well, we know we do trials for prevention, screening. We do very early phase trials for advanced cancers, but we do trials for patients who have localized cancers as well, for breast cancer, colon cancer, a number. So earlier diseases, because that's where the cures are going to occur, when we can find better treatment to treat patients with earlier disease. Clinical trials are dangerous because they use new medicines and practices. Well, we know that some of these investigational medications have risk, but they've been vetted, they've been analyzed, they've been reviewed in prior trials, so that, and then there's an enormous amount of oversight and safety precautions for any clinical trial. Participation provides no benefit to me. And again, the true fact is by participating in a clinical trial offers you access to some newer treatments. I can give you a number of examples in which we tested new treatments that are now standard that offered some patients enormous amount of benefit in terms of not only prolongation of life, but also survival and cure. If there is a clinical trial that may help me, my doctor will tell me about it. Well, I wish that was totally true, but that's not true. As much as we'd like it. Sometimes the doctors may not be aware of the clinical trial. They may be inclined to give you a different treatment aside from that on a clinical trial. There's always concerns about the patient-doctor relationship that the clinical trials interferes with. And some just don't believe in clinical trials. I can't drop out a study without jeopardizing the quality of my care. And I think that, again, is a myth. I think if you decide to be on a trial and decide to leave a trial, you will be followed on that trial and provide the same type of oversight that someone was on a trial. You're not on the treatment, but you will be continued to be followed. So the barriers to clinical trials participation are multiple, and I'll touch a little bit on some of these. There's structural barriers, and these are things that we run into in Hawaii. First of all, you have to have a clinic and access to a clinic that does clinical trials, right? And we're separated by water in many of the islands, and we really have actually a lack of access for a neighbor island. And I think the initiative of the Cancer Center will be trying to minimize that or work on that. There's also a lack of trials for a particular patient. So even though one wants to be on a trial, there may not be a trial. And that's about 50% of the patients, unfortunately. There's clinical barriers. What are those? Well, sometimes the trials are too restrictive. The eligibility or inclusion criteria too restrictive. So these are things that all have to be worked on. We know about the physician's barriers that might occur. And number one, a lot of patients are never offered a trial. And these are the barriers we have to kind of deal with. We have patient barriers, myths that they may believe about trial. One big issue is financial toxicity or financial issues about what it's going to cost on a clinical trial. And that's probably the second most major reason why people don't participate. They're worried about toxicity, there's concerns about being part of experimentation in certain trials. We have demographic and socioeconomic. We know there's age differences. Younger people tend to be on trials for some reason. Even though our population for cancer is much older, we don't see that same number of older patients. We have gender differences. We have certainly socioeconomic differences. We know that patients who have less insurance or fall into a lower socioeconomic group may be less likely to participate in a clinical trial. So we do have some major health disparities within the clinical research and clinical trials landscape that have to be addressed. And I can reassure you that we're doing that here at the Cancer Center. So awareness of clinical trials. How do you know about clinical trials? Well, sometimes your primary care provider will let you know about a clinical trial. We now do a mail out to as many people, primary care physicians who have been, who've had a patient who's been diagnosed with cancer. We have cancer care specialists like your oncologists. Patients call the cancer centers for information or help. You can get it online with cancertrials.gov. I think we see now television and newspapers publicize about clinical trials that are available for enrollment. And sometimes it's just word of mouth. Hawaii is a small place. And so, friends and family tell you about the importance of clinical trials. So with that, I'm going to stop and I'm going to turn the lectern over to Ashley Springer, who I've known for many years. She's dedicated her career to the care of cancer patients. She's actively engaged in the clinical trials program here and is one of the principal investigators actually of some of the trials that we allow nurses to be involved with. And she'll share her perspective for clinical trials. So thank you very much.
We have some slides. I don't have a lot of slides, but I first want to start off by thanking you all for being here. I want to thank the Cancer Center for inviting me, Dr. Cho especially. Like Dr. Cho mentioned, I've been in practice at Hawaii Cancer Care for going on 9 years now, and I probably would have never been in this position if it weren't for him taking a chance and hiring me back in the day. I also want to thank everyone who's ever considered being on a clinical trial, anybody who's ever participated in a clinical trial, and also the caregivers who assist patients with clinical trials. I think that without all of your participation and consideration, we wouldn't be here today having this discussion. So when I was first asked to present a nurse's perspective, I really didn't know what to talk about. And it's mostly because I don't think about what I'm doing on a day-to-day basis on clinical trials. It's just become so encompassed in my day-to-day activities that I don't really even think that this is clinical trials compared to standard of care. When I entered oncology, I really had no experience in clinical trials. In school, we don't spend much time learning about clinical trials. And that's with me doing an advanced practice nursing degree. So considering that so much of that is learning about how to be a part of the medical model, we don't learn one of the biggest assets to medicine in clinical trials, the things that developed what we are able to use today in practice. So a lot of what I learned was actually on the job training through mentors like Dr. Cho and some of the other physician counterparts. And a big impact was made by Krista Braun-Inglis, who's a real beacon for the nursing community with oncology here in the islands. And if it weren't for her, I probably wouldn't have as many roles as I do in the Cancer Center. So I'm really appreciative that people before me helped set the tone and the learning path for me in clinical trials. And I hope that I can share that with future generations, and most importantly, with my patients and their families. The role of a clinical research nurse varies depending on the population that you're at. So I'm in a community-based practice. We have 4 oncologists, hematologists, but we are one of the more active participants in enrolling patients in clinical trials. And that really comes because our providers truly believe in offering clinical trials to anyone who's potentially eligible. What I do to initiate the clinical trial process in our practice is that I review patients' charts. Every new patient that comes into Hawaii Cancer Care is reviewed by myself initially to determine whether or not upfront clinical trials are available to the patients. Now, most of our patients won't be eligible, whether it's due to some of those eligibility criteria that Dr. Cho mentioned, or sometimes we just simply don't have the clinical trials available to our patient population. If I do find a patient that I initially think it may be a good candidate, I often will spend a little downtime discussing the patient's care with their primary providers. A lot of times I may look on the outside and say a patient looks great, but somebody else who's seen the patient before might know a little bit more about their circumstances, whether or not they would be interested in trial, whether or not language may be a barrier. Some of the trials that we would love to offer only allow patients who speak or write in English to be enrolled in it, which here in Hawaii, we're so diverse. We have patients from all over the world, and that's a big barrier for some of our patients. Hopefully one day we'll be able to overcome. I work extremely close with the Cancer Center. As Dr. Cho mentioned, we have primary and sub-investigators that oversee the operations and review protocols, whether or not it's good for our patients. Sometimes I am working with research associates maybe 3-4 times in a day, so they are on my speed dial. Sometimes they don't enjoy that, but it's really important because our research associates are really the heart of the Cancer Center outside of our patients. They are the ones who advocate for our patients, make sure everything that we're doing is in the best interest of our patients. And I really want to highlight how important they are to making this successful and making sure our patients are well cared for. This figure just shows the many different members of a multidisciplinary team. In oncology, we have so many players that are here, but like Dr. Cho mentioned, patients are always at the center of our treatment. I went into nursing because I do believe that caring for the patient is the most important part of what I do. I think that it makes it a lot easier for me to bridge the gap between patients and physicians, just because I'm able to kind of dig a little bit deeper, have a little bit more time to spend with patients. But I work a lot with radiation oncologists who provide radiation therapy, surgeons, and other social work, financial navigators, all these patients who are an important part of the care that patients receive. A big chunk of my time in clinical trials is actually spent directly with patients. So I often am the first person to introduce clinical trials to patients. It can be an extremely overwhelming time for patients when you're first diagnosed with cancer, the kind of questions that you have are, how am I going to deal with this? What do I have to do? What kind of changes do I need to make? How long do I have to live? Can I survive treatment? So all of these questions are things that I really enjoy spending time and discussing with patients. Sometimes I might spend 60 minutes to 90 minutes going over clinical trials and other non-clinical trial options for patients, really trying to help them understand what they're going through, what to expect, and how this is a journey that we're all fighting together. I really have enjoyed spending that time because I think in the hustle and bustle of medical treatments and diagnosis, we're often going back and forth between testing. Here is another paper. This is a new medicine. You have to show up for this test. And I think that becomes really overwhelming for patients and caregivers. And so my focus is to really alleviate some of the stressors that can come with that. If a patient is interested in a clinical trial and they are eligible, we do send it to the CRAs or the clinical research associates to do a final screen for eligibility before I discuss consent. Now, informed consent, just like with treatment of any type, really is to make sure that patients know all the benefits and the risks that are associated with treatments. Whether this is clinical trials or standard of care, it really takes a lot of time to discuss with everyone what the expectations are. Because sometimes a provider might recommend the best care or a clinical trial, but a patient might hear some of the side effects or some of the follow-up requirements and say, this is not the best fit for me. And so it's part of my job to make sure that everybody is understanding of what's going to happen. And if there's any questions, concerns, that these are fully addressed before the patient is consented onto treatment. I am able to enroll patients onto clinical trials. That is something that's been added as part of my role as an advanced practice nurse in the past few years. And I think that's really helped expand the access of clinical trials to patients, because I'm able to not only work with the providers, but work with patients to look for clinical trials that maybe weren't thought about initially. A lot of my time is spent on study. Our oncologists are extremely short-staffed on the island and nationwide, but particularly, I think I heard one estimate that we're about 50% of where we should be on the island for oncologists. So our oncologists are extremely busy and don't often have the time to spend for some of the extended visits that happen while patients are on study. It's one of my roles to do medication or drug education and teaching. And in these, I'm talking about how to correctly take your medicine, if there are any interactions, as well as side effects. I do review all of the protocols that our patients are enrolled in. Some of these protocols are quite lengthy, so I always say I never have to go back to school because I read enough papers in a weekly schedule. I do oversee the administration of medications. We do have an infusion suite, so some of these medicines may be chemotherapies, targeted therapies, or immunotherapies that are administered through your vein. And I also help coordinate the medication oral adherence program in our practice. And so that helps make sure that patients are safely being administered in our treatment office, as well as making sure patients are safely taking their medications at home. A big thing is safety. One of the most important things about clinical trials and treatment in general is making sure that the treatment we give you is not only effective for you, but that we're not causing undue harm. And so what I do a lot of times during my visits with patients is monitoring for these adverse events or side effects. And that includes grading the severity. Is this something that's mild and that we can just watch? Or is this something that requires intervention and maybe potentially even stopping the medication? I do usually have to determine whether this medicine or this adverse event is related to the clinical trial. Is it related to the patient's disease? or if it's something that's just incidental. I also help as an advanced practice provider, which is separate from the nursing part, is treating these adverse reactions. So I may be prescribing medications to help mitigate some of the side effects. And I often will refer patients if there's something that I feel that someone else would be better suited to help them with. Occasionally, if there are things that are going a little different than we anticipate, we do collaborate with the study chairperson. And this is the person who is usually at one of the larger consortiums that are helping oversee these protocols. They're usually off in the mainland, so coordination can be tricky at times. During off-study visits, I continue to follow patients. So, I always say, don't be scared to come off of a clinical trial. If your time is ended, don't worry, your care is going to continue. The same quality of care that you expected and that you received during clinical trials will continue even off study. You may not have to come in as much. You may not have to fill out some of the questionnaires, but I promise that we will continue to follow you and we'll treat and monitor for any long-term adverse events. And I also help navigate the treatments after clinical trials. So as we discussed earlier, this is not the end of the line treatment options. These can be something that's given really early in treatment, kind of maybe a little later. And of course, there are some that are reserved for later lines, but this is not it. And it's my goal to help manage things and help guide treatment options after a patient has completed a clinical trial. My particular role expanded, as Dr. Cho mentioned. I've been fortunate to be selected to be a site investigator for a clinical trial here. That is an alliance trial that is looking at hot flashes for men with prostate cancer. It's been a particularly interesting study. So men who have prostate cancer may go on medication that suppresses testosterone and makes them have symptoms similar to women going through menopause. And so we've known how to manage menopausal symptoms for women for a long time. So now we're trying to help men deal with hot flashes from prostate cancer. I do serve as a sub-investigator, so I help coordinate and enroll patients on various trials at Hawaii Cancer Care. We're very fortunate to be able to offer expanded trials to some of the trials that maybe aren't as popular and have small patient populations. At the UH Cancer Center, there is a really big initiative to make sure that we're bringing clinical trials that are really relevant to our patient population, that we're not opening trials just for the sake of opening trials, that we want to make sure that the patients who need it here actually get access to it. And one way that they're doing that has been developing disease site working groups. And the three that I help participate in is the hematology. So we're dealing with a lot of the blood cancers and blood disorders, thoracic, head and neck, so lung cancers and head and neck cancers. And the biggest one, probably the one that I'm most active in, is the CCDR, or symptom management. So these trials are really there to help look at how we can best help patients who do develop symptoms, whether it's from their disease or from treatments that are related to, or symptoms related to their treatments. And we've been able to really focus on bringing trials that we think will accrue well to help mitigate some of the complications that happen in cancer. I do also help review some of the cooperative group trials. That again is like going to school and having to do an analysis of a big book that you just read, but it's actually very interesting, and it's helped me understand the importance of the trials, the complicated aspects of the trials, and how we really need so many people to be a part of the trials team to help make sure that all of these are available to our patients. And then most recently, I've been able to advocate for our patients through some of the national research and quality improvement committees, particularly within advanced practice providers. making sure the treatments that we offer, the voice of Hawaii is heard and recognized across the nation. Lastly, I wanted to finish on a patient's perspective. So as I mentioned, I spend a lot of time with my patients, and I really wanted to find out if what the nurses, what I do helps our patients. And so this was a patient that I saw actually in follow-up today who was on a clinical trial for pancreatic cancer. As you know, pancreatic cancer is one of the more aggressive cancers that we have here, and we're seeing it a lot in younger patients. And so a lot of these patients can go through a lot of treatment. And this patient in particular went through a clinical trial after his initial therapy didn't work. And he wanted to just share that he felt that nurses were always on it. They were always 1 or 2 steps ahead of me every time I had an issue. They constantly checked in on me, and when I had side effects, they always helped to manage my issues and made sure I saw the appropriate provider when I needed. My clinical trial treatment wasn't easy, but they helped a lot. They were great. I'm forever grateful, as I mentioned earlier, for patients like this one who participated in trials. And I also want to say thank you for all coming out tonight. If you have questions about clinical trials or what a nurse has to offer, please don't hesitate to reach out.
Thank you very much, Ashley. Our next speaker, very honored to have Andrea Bacos from Maui, who will share her story as a caregiver for her husband who was afflicted with cancer. And again, our hearts go out to you, Andrea, and all the people in Maui that's happened in the past week. So we feel very honored for you to take the time to share your experience with us under the circumstances. Thank you very much.
Okay, aloha, everyone. My name is Andrea Bacos, and my husband was Lance Bacos, and we're from the island of Maui. I work as a lay navigator at Pacific Cancer Foundation on Maui, where neighbor islands oncology services are very limited. So I'd like to begin by thanking, first of all, our Heavenly Father for actually allowing me to be here tonight with all of you. A few days ago, Michelle found out that my kids and I lived in Lahaina, and we had lost everything in the fire of Lahaina. Michelle shared with me that she understood if I wasn't going to come tonight to share my husband's story due to our current situation. After speaking with my son, Waylon, and my daughter, Tori, that I didn't want to come to Oahu. It was just too much for me. My kids actually rounded up me and said, Mom, Dad never gave up during his diagnosis. He never gave up during his darkest days. We're not going to give up now to go to Oahu and share that story. On January 1st, 2018, I took my husband to Kula Hospital, to the emergency room, because he was spitting up blood. After running numerous tests, the doctors asked me to take a picture of the computer screen of his and to find my husband, a lung doctor, on Monday, because it was a holiday, and sent us home. After going home, the kids and I watched my husband bleed while he was sleeping through his mouth, and he was coming discolored. So we flew him to Honolulu and went to Queens ER. That is when my husband got diagnosed with stage 4 liver, lung, and brain cancer. It was not curable, but they were going to try to treat. Within days, Queens assembled an amazing team of doctors, which my family called my husband's doctors the dream team, because they fought, they did clinical trials, they did everything that they could to prolong my husband's life, as it wasn't looking good. His tumor was wrapping around his esophagus and closing in fast. While at Queens, my husband endured 3 rounds of IV chemo, 23 rounds radiation, all back to back. And he was given immunotherapy and finally placed on oral chemo. Being placed on oral chemo allowed my husband and I to return home to Maui, to where my husband was able to spend as much time with family and friends. This was the biggest gift given to us because we could be with our children who was still in high school. Going home to Maui was where we needed to be. And that's because of the clinical trials allowed my husband to leave Honolulu. I asked my husband, now we are home, to give me a bucket list. What's your bucket list, Dad? My husband's bucket list was 1, seeing his daughter graduate from high school, and he made it. 2, see have snowfall fall on his head. He made it. We took him to Alaska. 3, we never been to Vegas. I took him to Vegas and he surely enjoyed it. Didn't want to come home. 4 was seeing our Waylon, my son Waylon, follow in Daddy's footsteps and got sworn in to the local union, the local plumbers union, local 675. And 5, my husband wanted to make it past the 2-year marker that was originally given to his life. He made it to 4. Lance and I traveled every month to Oahu for doctor's appointments, treatments, etc. It did cause a financial hardship on us, but we had to do it because everything was here. Neighbor islands are so limited with anything, even to get into an oncologist. I work with oncology people. Even today, my day-to-day work is a struggle. We have nothing there. On December 30th, 2021, my husband lost his battle to cancer. Lance woke up that morning and said, Mama, I'm going home to heaven today. We had our special talk. Lance had his last words with the kids, called all his brothers, which one of them is here tonight, Precious, said his goodbyes. It was a sad day for the Bacos family, but it was a proud day for the kids and I, as my husband battled more than we could ever ask. He endured all the pain, but with courage. And for that, he will always be our hero. Thank you.
Thank you very much, Andrea, for coming and sharing with all of us your story. Really appreciate it. Our next speaker is Monique Inovai, who lives on the other side of the island. And I think, I think one thing about clinical trials, it brings opportunities for many patients or participants to do things that they have not done or had access to. But once they get on a trial, they feel very dedicated to the trial. And they put all their all and heart into it. And we at the Cancer Center appreciate that, because without our participants, it'd be very difficult for us to do the work that we want to do and accomplish. So, I want to welcome Monique, who taking time to come over and share her experience as a clinical trial participant.
Andrea, thank you. You're the reason why the big question in my mind was what it was today. Tuesday, August 15th, which is today. Little bit of brain log. 5:20 a.m. alarm goes off, 30 minutes late. On my phone, UH Cancer Research Center event. Wish I could reschedule for next week. How am I relevant to TMIST again? And what does it even stand for? But back to today. Prayer, personal study, HIVA fitness. Which do I skip since I'm running late? Gotta pray and really trying to be more serious about my health, so no excuses. Dancing HIVA will help. And once I get there, I'm always glad. Find iron among the moving boxes so I can prepare my last kindergartner's collared shirt for today's first day of school. Check. 6:45, home from HIVA to find kindergartner cried to wear a different shirt. Check. While making special first day of school lunch, Wonder how mom is since she drove 19 hours over the weekend to visit her childhood friend, Nancy, diagnosed with breast cancer a year and a half ago. How am I relevant to T-MIST again? Well, my mom and someone I love maybe make me relevant. Pause, deep breath. Healthy breakfast, check. Healthy lunches made, check. Hugs and kisses, check. 12-year-old daughter, running late, but with a sweet attitude as I'm trying to be patient, check. Wondering how my nephew, Cosmo in Canada, is doing on palliative care, losing the sight in his second eye, and hoping that he'll be able to meet some of his cousins all the way here in Hawaii. Pause, deep breath, and love. Helpful husband drives older children off to school before first day of school photo. Before first day of school photo, check. Good husband drives back for photo, check. Town is so far away and I don't have a babysitter, and now is the really wrong time to have money to pay for a babysitter. I'll need to prep for dinner and leave by 2:30 just to make it there in time with traffic. How can I make this event more meaningful to me personally? I wonder if my dad's sisters get regular mammograms. I'll text them and maybe they'll be willing to help me with ideas for tonight. What about my 5 sisters, of which I'm the eldest? My mom, my stepmom. Wow, there are so many women I love. Would they have felt comfortable or been willing to participate in T-MIST? Were it not for Kalo, her vibrance, her personality, her perfect balance of persistence and genuine care, and insisting that she drive me to town, I don't think I would have had a mammogram last year. I know I would still be meaning to get a mammogram this year. Those 2 young girls that asked me questions, they were professional, friendly, and polite once I showed up at Queen's Hospital. But if we had gone on that walk together to the second building where we chatted casually before the questions, I think I would have felt more comfortable. Would my dad's wife have felt comfortable? Would she have understood the medical terminology, even though they were trying to be so polite in explaining, since English is her second language? Would I volunteer my grandmothers to participate? Maybe, if there were a few changes made. But good thing Kalo told me that changes have been made. So maybe I would encourage them all. But back to school, because the new kindergartner needs a change of clothes. Accident on the first day out of his control. Talk to him, hold his hand, get a drink of water, and then back home to run my other daughter to piano lessons. A text comes through from the aunties. Even though there are a dozen of them, some of them reply, 10 years since one auntie's last mammogram because it was painful, and another has them regularly. I wonder if the technology has improved at all so that I can assure them that the pain is less. All immigrants from Tonga, now living in 2 countries and in several states on the mainland, all made their transition into the mainland United States through our state. No correlation between those who have had exams and those who have had college education, those with corporate jobs, those whose dominant jobs have been motherhood and remaining home. Some of them have and some of them haven't. 11:30 a.m. Follow up with Kalo and Michelle about tonight, appreciating their genuine kindness. Appreciating and looking for that photo with Kalo, who remembered me months and months later to invite me to a luau with all the women participating in this study, where we could just be together and share our stories, ages 40 into their 70s, all of us having had a first mammogram in this past year. 11:53, oh, my sisters, sorry, slide out of order. my sisters, my mom, my stepmom. 11:53, back to school, waiting for the new kindergartner, and a text comes from my mom in Arizona, who went to visit her friend. Nancy passed away at 8:28 this morning. It was a peaceful passing in the morning. A rough night for all of us. We were right there with her when she took her last breath. Pause, deep breath, wipe the tears away to get to the kindergarten classroom. 12:05, kindergartner, even with the accident and the change of clothes, still managed to have a good first day at school. But driving home, thinking, how am I relevant to this event today? That question doesn't matter to me anymore, I suppose. I think of my sweet friends who lost their mother this morning, and I think of my own girls. I think of my good husband who arranged his work schedule to come with me today. And then I think about this whole day. The first conversation I had about mammograms with my aunties, the first conversation of text I had about mammograms with my sisters, who are all younger than me. And then deciding on the way here that Kahlo would be proud of me if I made a phone call to Queens to schedule that next mammogram. Last year we played phone tag and they wanted me to follow up and said I needed to have a follow-up, but as the months went by and the phone tag continued, it never happened. And now all of a sudden it's a year later. So when I left them a message today, I wondered how long it would be till they called me back. But 15 minutes later, they called me back. August 24th, 9:25 a.m. I'm scheduled for my second mammogram next week. Check. Timist and Kahlo helping me forge a new path. Check. And now that I'm here, I'm so glad. Check. Commitment to encouraging others to join a clinical trial? Absolutely. Check, check. Thank you.
Thank you very much, Monique. I want to turn your attention to the back table because back there we have beautiful people who are representing some of the trials that we're doing here at the Cancer Center. So feel free to ask them questions and pick up some of the information. I'd also like to introduce Kahlo here in the back of the room. Kahlo is part of our family here at the UH Cancer Center. He's an advocate for us in the community, certainly with Monique and our mammogram studies. So, welcome. Kahlo. Yeah.
Hello, everybody.
Yeah.
I'm a two-time breast cancer survivor, and they saved my life. The Cancer Center saved my life. When we put this thing together, I had no clue at all that we were going to be crying because we've had three amazing people up here. And I just started last year and I was at Laia and I said, hey, Monique, have you had a mammogram? That's my outreach. I speak different languages, but hey, have you had a mammogram? And this is the reason why. And so I thank you. Thank you so much. So that's my little 2 cents.
And, we at the Cancer Center, it's been a difficult time in the last 3 years because we had COVID and we had issues in terms of, as everyone, in terms of staffing. And we've now recovered at the clinical trials office. We're just about 100% staff now. But I want to share, and we have this for anyone who might be interested in the audience, that the UH Cancer Center, we actually formed our own program to teach clinical research associates or professionals. So we actually run an annual program to get people into the field. So I'm going to share this, and if anyone out there would be interested, please pick up a brochure and we can answer any question. So I think now is a good time to have all our speakers come up, and we'll have a question and answer. I ask that if you have a question, you come up to that mic there and just ask your question, and that people on Zoom at least mute yourself, but you also can ask questions. So through the chat, is that right, Michelle? They can do it to the, so you'll let us know your questions. Okay. So don't be shy, come up, ask questions of Andrea and Monique, Ashley, and certainly myself as well.
You guys don't want to give me a mic, really. In my family, I'm the prodigy on the mic. But anyway, hello, I'm Alexis. I'm Andrea's sister. And so I'm so proud of her and the 4 years that she was there for my brother-in-law. She was amazing and just super manawahine kind strength. So good job, sister. Question. If I wanted to be on a clinical trial, can I ask the cancer center to be a client, or do I have to go to my primary care physician?
The Cancer Center doesn't take patients themselves while they oversee, and I guess the better question would be, it depends on the clinical trial that you want to be on. Some of the screening prevention actually can be overseen by the UH Cancer Center. If it's a treatment trial, they can actually help you navigate to find a provider that can help you determine whether you are eligible, and then, discuss that further. Is there anything I'm missing, Dr. Cho?
Yeah, I think there are different ways of getting into the system for a clinical trial. Obviously, your primary care physician would be your first contact. And I think patients now have to advocate for themselves, right? And so part of our effort is to bring awareness to clinical trials. So patients or participants know when they go to their provider, even their primary care provider or the cancer specialist, is that clinical trials is part of the conversation. You talk about different treatment. I think patients or participants have to bring that topic up, and that's what this is all about, make you aware. But there's different ways, as I pointed, primary care physician, but you can call the Cancer Center on our website, and we can help you navigate that as well. But I think the primary care physician and your cancer care specialist will be the access to the clinical trial.
Hello, thank you for sharing tonight. I think I have a specific question, but I got to get there. I was diagnosed with pancreatic cancer last November, and I went through the standard care treatment, so FOLFIRINOX, for 2 months, and it didn't work. So they switched me over to the gemcitabine Abraxane. Went through that for 6 months. Finally found a doctor who would do surgery on me at USC literally 2 weeks ago on August 2nd. They opened me up. He did laparoscopy and didn't see anything, but later did more exploration and found spread in my abdomen wall. So I'm now considered stage 4. I didn't even know about, I didn't really know about clinical trials. And we still, my wife and I are now navigating this. We know that pancreatic cancer is very aggressive. And my last treatment was on July 13th. So I guess the question that I really have is, for a local person like me who, my local oncologist is here, who's not necessarily a specialist in pancreatic, like other cancer centers in the mainland have more specific, like GI oncologists that will be more familiar with this disease. How can, I guess I'm kind of looking to the future of helping others that suffer this in Hawaii now, because I only knew that there was a standard of care, and every time one standard of care didn't work, they just said, we're not there yet as far as clinical trials. We're not there. Because I was initially stage 3, and the goal was to shrink it enough to get to surgery. But 10 days ago, we found out it's no longer stage 3. So in my situation, I'm just, again, maybe for future patients, how do you, with an aggressive cancer like this, how would you guys suggest? I've read a testimony of a former doctor, not here but on the mainland, that went straight to clinical trials after his stage 4 diagnosis of pancreas cancer and didn't even go through the standard treatment. He refused FOLFIRINOX and went straight to trials, and he's living today because the trials saved him. And so how would you, I know hindsight's 20/20 for me, and now I look at it and say, I wish I would have went for a clinical trial earlier, but I am where I am now. So maybe it's for the future patients like me who just don't know where to go or what to do, or, what would you suggest? Living in Hawaii too, which is another challenge.
Yeah, you bring up a lot of really good points. Here in the islands and a lot of places across the nation, community oncologists aren't specializing. They have to be generalists. We don't have the resources, unfortunately, as some of the academic centers. I think a lot of the doctors, they wish they had the opportunity sometimes to specialize. And I think as far as like treatment moving forward, there's always that discussion. I encourage patients to advocate for yourself, having that constant discussion. Maybe at the time there wasn't a clinical trial. That's not to say there isn't one available to you now. There have been a lot of developments in the way we treat patients. Now we are looking at personalized medicine and looking at tumor-specific treatments, whether that's on a clinical trial or not. So I definitely would encourage you to speak to your oncologist about, what other options there are, even beyond traditional therapies. I think it really needs to, without stepping on anybody's toes, having that thorough discussion about all treatment options. There are clinical trials that are open. Here, I think we are still limited in pancreatic cancer. There, with trials, the number of trials that open, major academic centers do often offer clinical trials as the first line. In practice, actually, we say offer clinical trials whenever we can. It should not be thought of as a secondary or last option. If there's a trial available, if you are willing to travel, sometimes it may mean moving and seeing a treatment facility in the mainland. The oncologists here, I can definitely tell you, they are keeping up with the knowledge. I don't think in Hawaii we get any second standard, practice because our doctors are not affiliated with a major academic center. We have a lot of our principal investigators are leading the charge on some of the gastrointestinal malignancies here. And so I would definitely say, we can have a little talk after. I'll give you my contact information, but it is something that, maybe initially wasn't there, could be, maybe not. But there are treatments, definitely.
Good evening. Thank you for the talks. My name is Ryan, and I am a first-year medical student over at JAPSOM. My question was, so one of the barriers was the fact that physicians just don't know about the clinical trials that are currently available. So it's going to be 7 years down the line for a lot of us, but for myself and my classmates, what resources would we look into to follow what clinical trials are ongoing and what could be offered to our patients in the future?
I think with the internet, the world is much smaller, right? And just in comments to yours, I remember when we did a trial in which we compared gemcitabine to gemcitabine and paclitaxel. So, your treatment, which I'm sure has helped you not as much as we wanted to, at one point was a clinical trial. And so again, just to stress that clinical trial does move the needle. We do find better treatments. Not optimal, we need to continue to search, but there it is. The world is very small now. Internet allows us to find so many things in a very short period of time. You have clinicaltrials.gov. You can even go on Google and find the clinical trials and what centers are doing specific clinical trials. So there's an enormous amount of access that patients have, the power of the computer and the internet, that allows you to gain the information. And again, it's all about, making sure that as one plans one's treatment or its diagnosis, that becomes part of the conversation. It may not be as the best, but in certain cancers, clinical trials can be the first line treatment for them and not be able to burn a bridge for subsequent treatments. So that's the mindset, I think, that we, in the clinical research is to be sure that's part of the conversation from day one.
I think just from my sake, clinicaltrials.gov, from a person who doesn't know how to use it, is extremely overwhelming. So I probably say it's something that we have the opportunity, or we have the luxury. We have a great team here at the Cancer Center who every month now they send out a list of what open trials we have locally. But clinicaltrials.gov, it's really great because it gives you access to what's open here as well as nationally. So you can use just simple keywords as breast cancer or stomach cancer, and it can actually look at different trials that are open. But I would definitely, when you start moving along, I have a priority list. It's what we call that I have printed out, and it's on my desk every single day. And I do think that there is some of information available on the Cancer Center website. I know that before we did have the ability to look up trials by disease states here.
And maybe Michelle can speak to this too, is that we have the Cancer Information Service, not here at the Cancer Center, but it is a 1-800 number that you can get access and speak to the NCI. And they will provide information about the cancer, the stage of the cancer, where you live, where you would want to visit institutions, and could give you information on clinical trials to meet your.
That's right, Dr. Cho. The number is 1-800-422-6237. 1-800-4-CANCER. So can I do a couple of comments and
Sure,
questions
go ahead.
from those that are online? So one comment from Elena. She says, thank you so much, Dr. Cho and Ashley, for your helpful insights. And Andrea and Monique for sharing your heartfelt journeys and stories. Okay, so yeah. And from Natalie, and this question is for Dr. Cho. Has Hawaii pursued setting up a just-in-time clinical trial research screen site through Pharmatech?
I'm sorry, what's that?
It's just-in-time clinical research screen site through Pharmatech. Yeah, actually.
So actually, yes, Hawaii Cancer Care actually does participate in just-in-time. So just-in-time trials are actually clinical trials that are matched to patients who undergo genomic testing or tumor profiling. So I mentioned personalized medicine. So one of the things that we're doing now is actually looking at patients' cancer more in depth, looking at the genetics, looking at DNA changes that might make us treat their cancer in a more personalized manner. And so some of these next generation sequencing platforms actually are bringing trials to areas that might not, because maybe there's one patient in 10,000 that might have this mutation. So I would say that I'll leave my contact information and, we could potentially, see a patient per consult if they have been matched. But we are participating with a few.
Yeah, and along these lines, I mean, within the cancer community here in Hawaii, we have, as part of the UH Cancer Center, what we call Hawaii Cancer Consortium, made up of Queens Medical Center and Healthcare, Hawaii Pacific Health, Kuakini, Adventist Health, Castle on the windward side, and HMSA. And the movement here, because is to find using advanced technology and artificial intelligence in trying to match patients to trials. And so there's a number of platforms. We actually are looking into that, the Cancer Center and the consortium, to be sure that no one is, like you say, just in time, when no one's left behind, because we probably miss patients who would otherwise be eligible for trials that are not being, matched with the trial, because this is all done by screening and by manually by humans. And so we are looking at that platform here at the Cancer Center. And I had a question for Andrea, because when your husband was diagnosed with what appeared to be a very extensive cancer, how did clinical trials come up in the discussion?
So clinical trials came up, actually, our oncologist came back from a seminar, MD Anderson. He came back from MD Anderson. And my husband was doing all these tests, biopsies, and we had discovered what gene was activated, which was the ALK. When my husband was diagnosed, there were no medications for this, none. It was still clinical trial. And just so happened, our oncologist came back with some samples. And for us, when you hear the word clinical trial, to be honest, it just freaked us out because we didn't know what that word was. I mean, cancer hits, we all know what cancer is, right? But when it hits your forefront, your foundation, and doctors are throwing all these terms at you, and I worked medical field for 15 plus years, so I am familiar with the medical terms. But when they're throwing all of this and the word clinical trial comes up and you're just digesting, you got diagnosed with cancer and it's uncurable. That was very hard for us to really understand. But again, that's how it came up. Biopsy just so happened came back when our oncologist returned to the island. And he said, you have ALK translocation, which now becomes they targeted the gene that was active, that was everywhere. And by the grace of God, my husband's cancer, his liver, lung, brain cancer, were all ALK. So normally they can have multiple different genes that are activated, but in his liver, lung, and brain and adrenal gland cancer, it became later, all became L. So that's how we got to go on clinical trial.
Because I would gather that, you know, his prognosis, when you were first told his prognosis, was very different than the story you gave in terms of how long. I mean, you know, wasn't cured, but certainly his life was made better and prolonged by.
I think his life was actually made extremely better. Again, we're so grateful to be having the opportunity. When we did the IV chemo, the you know, straight in, that put my husband out for 21 days. He was throwing up and bedridden. And he actually prayed every day to go home to Heavenly Father already. He was done. And just so happened, like, again, our oncologist said, no, I'm not done with you yet, Lance. I have something I think you should try. Again, we contemplated, we're like, clinical trial, that's like being, you know, a guinea pig, you know, in our mind, we're like, okay, we're going to guinea pig. My husband looked at it as one way or another, he's not going to get cured. Cancer will take his life. And that was inevitable. So yes, with that, we were given longer than we actually supposed to. I can tell one story. Our lung doctor, when we walked into his room, his office a year after my husband was diagnosed, he just said, "You're still alive." And we were like, what? You know, he couldn't believe my husband was still walking, talking. I have, you know, some people that know my husband in this room. If you saw my husband, how he looked on those pictures, it's exactly what he looked like the day he passed. He had no side effects, zero whatsoever on clinical trial.
Okay, this question is from Barb. How do folks get involved with MD Anderson? I hear Queens is partnering with them. What are the other locations that are partnering?
I'll speak a little to that. I don't know, but the Queens has developed at least several years now some partnership with MD Anderson in terms of you know, improving their cancer care delivery and again some access to clinical trials, like you say. Hawaii Pacific Health has partnered with the Fred Hutch in Seattle, Hutchinson, and the Seattle Cancer Care Organization. So yeah, the hospitals have taken approach of trying to get expertise into their healthcare system. And that's the only two I know. Yeah.
And this is for Monique. So living on the island, Monique, and knowing where you were going to be taken to, can you explain how and why it made you just realize that it was important to be part of the clinical trial?
Well, like Andrea, the idea of a clinical trial, I'm somebody who I rarely go to the doctor. When my children are sick, I take them. Thanks to modern medicine and technology, they're able to diagnose them. And then I go home and I usually treat them in my own ways. And I bring them back for follow-up and the doctors will say, oh, that prescription worked or this. And I just nod my head because I like to do things a different way. And it's been usually very successful. So this idea of like a balance between modern medicine and holistic things, the minute I walk into a doctor's office, I can feel it really quick, whether they are whether they're willing to hear my philosophies and work with me or not. And so also culturally, my husband's side of our family, my father's side of the family, not keen on going to the doctor, really. So I felt like because I'm able, that making my way to town would be worth it. I don't know my way around town. So Carlos, I know I'm a very able person. But just the whole logistics of it, I still use MapQuest. If I go anywhere after Costco, other than straight home, I still have to find my way around. It's just kind of the way it is. But I thought maybe it would be helpful in some way. I wanted to help Kalo, and knew that the things I'm talking about are very common amongst a lot of women of all ages where I live. So I thought it might be helpful. Does that answer the question? Well, we've always lived in Hauula. If you look at a map, it says it's an hour, but if you're not familiar with town, you have to consider the traffic, the parking, the making mistakes on the one-way roads and all of that. So that's why, like today, my husband said, we better leave at 2:30. Of course, we're running late, so it was like closer to 3. But all of that, and my kids are home. I'm hoping they're okay, So all of those things, the logistics of it.
Okay, I just want to, maybe we just close it, there's no other questions, that if there's any questions about clinical trials, please visit the University of Hawaii Cancer Center website and the information. We have a phone number that you can call on the website. Also, I want to just make for everyone is that, here at the Cancer Center, Monique and the study she was on is just an example of what we're trying to do to minimize the health disparities that occur across race and different cultural groups, because we are a very diverse population. So here, that's our mission, is to be sure we have equity and diversity and inclusiveness of all the population that we serve. Joan.
Mine isn't a question, mine is a comment. When I hear women say, I don't want to get a mammogram because it hurts, it drives me bananas. It really does. Because usually whenever I went for a mammogram, I'd say flatten those puppies as flat as you can get them. Because then, especially if you have dead breasts like I did, that's the only way they're going to see anything show up. And I had microcalcifications in the breast, which warranted a core biopsy, which eventually led me to an experimental protocol. I had stage 3 metastatic breast cancer, and I only had microcalcifications in the breast. And if I hadn't had that mammogram, I wouldn't be here. That was 30 years ago. So I can't emphasize enough. It's like 10 seconds of pain. If you can't suck that up, I mean, it could save your life. So that's all I have to say.
Okay, I think we can, spend the rest of the hour kind of mingling, and again, feel free to visit the tables and these beautiful people in the back, share their research, and we have some refreshments. And if there are any questions you want to speak or talk talk to us up here, we're more than welcome to. So again, thank you everybody for coming. Those on Zoom, thank you for attending this session. I hope you learned a lot. Thank you.
Thank you. And for those who are here, if you could please turn in your evaluations. We would really love to help better this program. And so right at the door, if you could deposit your name tags as well as your evaluations. For those online, thank you so much for joining us. And this has been recorded. So we're going to be posting it on our website as well in case you missed it or want to share the information with others. Thank you so much for joining. Those online, we will be sending the evaluation tomorrow by email. And so we appreciate all that you folks are doing and for being with us tonight. Mahalo nui loa, and see you next month at our September 19th Quest for a Cure prostate cancer event on September 19th, 5 to 7 p.m. Thank you so much. Have a great day.